Thanks for the kind introduction and thanks for your time today. So let's move on. So as per the introduction, I did my PhD in breast imaging in the 1990s. So I've spent the last 25, 30 years now dedicating all my efforts really to reducing mortality of breast cancer. The reason we got into breast cancer was because 500,000 women a year die of breast cancer. My aunt died of breast cancer. My sister-in-law died of breast cancer. And Professor Mike Brady, his mother-in-law, died of breast cancer. So for us, it's been a very personal journey, all the way through, very focused on this, and we remain totally dedicated to constantly improving what we do, to constantly improve care to women and reducing that mortality from breast cancer. So the PhD at the University of Oxford generated all the concepts for what we do today within Volpara. We tried to commercialise it from Oxford. The market wasn't ready, and I'll explain why that was shortly. So Mike and I went into brain imaging. We were very successful, and we sold that company to Siemens in 2003, at which point I moved to New Zealand, which is why we are a New Zealand company based in Wellington, albeit, as per the slide here now, we've got a very strong team over in the US as well. We've got all the regulatory clearances now for our software, FDA, TGA, and so on. And we've got recurring revenue around $5 million as of today, and we're up to about 5.6% of the US market. So one of our aims for this year is to get to 9% of the US market. So that's 9% of all the women screened in the US. That's 40 million women coming through our software. Not only does it give you recurring revenue, but also, as per some of the other talks, that's a huge pool of data on which to start applying AI or new AI beyond what we're already doing. So I'll jump into some examples of that in a second. Let's talk a bit about what we do then. I'm going to start up here on the right for a change in this talk, just in terms of breast density. The PhD I did was all about computation, automatically, objectively breast density, which is the amount of white tissue in the breast. In the year 2000, no one gave a damn about breast density globally. Clinicians globally didn't understand it, didn't know how to use it. In 2009, after I'd moved to New Zealand, I sat down and talked with Mike Brady again, and we said, the market and the clinicians are now ready for breast density, that there's a wide acceptance of it, that there's hundreds of papers literally proving the importance of breast density to a woman's healthcare. So therefore, we should go back to the work we did 15 years ago. Now is the time to commercialise it. So we've now become world leaders again in the automated measurement of breast density, with over 270 papers coming out over the last few years on that. So that's been our real flagship product for a while, and I'll show you some patient scorecards. We've also become world leaders in judging breast positioning. So if you look on the screen here, you see the left and right breasts. They should be symmetrical, so there should be good kind of symmetry between the sides. Also, though, you look for things like the nipple should be in profile as well. You should see fat along the chest wall as well. All those things indicate that you've got a good image, you've got all the breast tissue on the image, and if there is a cancer present, the radiologist has got a good chance of seeing it when it's on there. So again, we are world leaders now in the measurement and reporting of breast positioning. So we can say to people, look, you're doing a really good job, but your breast positioning isn't so good in terms of nipple and profile. This is how to improve it. Then just moving over there to the left-hand sides. We've also become world experts then in measurement of breast compression. So the breast is compressed between these two plates. That's to stop the woman moving during the X-ray. If she moves, you get a blurred image. So you want to compress the breast enough so she doesn't move, but not too much that she feels so much pain she never comes back. So there's a real kind of compromise situation in there. And finally, in terms of one of our kind of key scientific points is radiation dose. X-rays are very low radiation dose, but they do, they can induce breast cancer. So something like one in 100,000 women will have a cancer induced by screening. So it's a tiny number, but if in the US you do 40 million a year, that does start to add up. So we've become world leaders again in measuring and ensuring the safety of patients by monitoring radiation dose. And one of the keys there on radiation dose is you need to know the breast density to measure the radiation dose accurately. So that's kind of where some of our key science comes in. Now, these X-ray machines here, we're a software company. These X-ray machines are made by GE, Siemens, Fuji, Medtronic, Metaltronic, there's numerous X-ray machines. One of our big claims then is being able to work on almost all X-ray machines that are out there today. So this is our first product. We launched this in 2010. I wish I had two laser pointers, but I'm kind of tricky, so I'm just going to point to this one. This is our patient scorecard. So if you go down to Imaging Associates in Melbourne or Monash, MIA down in South Melbourne as well, all the patients there will be getting these little scorecards popping out. So this tells you, the volume of the breast, the overall breast density, and then kind of a grade A, B, C, or D. So an A is a very fatty breast, and a D is an extremely dense breast. The women up here are 4 to 6 times more likely to develop breast cancer than the women down here. If the cancer forms in a dense breast, it's very hard to see compared to if it develops in a fatty breast. So there's a real double whammy for women with dense breasts. Our role in breast density then really is several. It's one, to provide a consistent score of density. It's very subjective doing this by eye, but two, to do it with very good workflow. So last x-ray is done, within 2 minutes we flag up and we say, Mrs. Smith, you've got a dense breast. Whilst you're here, we're going to do ultrasound on you. Okay? Rather than having her go home and then you write to her and say, Mrs. Smith, you've got dense breasts. We didn't see any signs of cancer, but come back just in case. All the evidence says that women do not come back if you write to them. I'm just going to note down here that there are many US state laws now saying that every time an x-ray is done, a woman needs to be told her breast density. The FDA commissioner last week came out and said he's now utterly convinced about the clinical benefit of breast density, and he's now looking to make it a federal law effectively to tell all women their breast density. That is going to be a big trigger point for us in the US. I'm just going to note here, there was a breast density conference 2 weeks ago here in Melbourne. It was outstanding. Australia's got a group of world-class academics in this space. So there's a lot of discussion now in Australia as well about telling women their breast density, so women understand how good or how bad breast screening is, and to give them the option that they might want to go maybe private to have ultrasound done, or even to investigate breast MRI as an additional imaging routine. So we made our name with breast density, but then we listened to customers, and customers said, well, this individual information is great. Can you tell me about my whole population? So that launched us into the world of the cloud. So all this data now flows into the cloud, and then imaging analytics and AI. So we now produce these dashboards. You can log on to a dashboard. You can see the results of 10,000 women. You can see how all your staff are performing. You've got the objective evidence to go to a technologist to say, look, you're doing good work, but you're over-compressing the breast, and we're getting too many complaints. Please modify how you compress the breast. Or we can provide the evidence that says, this x-ray machine over here is not working properly, it's given too much radiation dose. Go and tell GE or Hologic they have to come in and fix it. Right the way through to we can tell the imaging manager about productivity of her machines, but also we can tell her about her population coming to see her, and she can use that then to target GPs who then refer women to her. So this is a very powerful tool. In the US, it's all about, we are very US focused. In the US, it's all about proving you improve patient comfort, but also there's a return on investment story, so I'm going to touch on that. I'm going to note here, we are increasingly bullish about Australia, and these are the sites in Melbourne. We do have one of our lead clinical people with us today, Kylie Chandler, who was one of our big users at Imaging Associates and basically said, I love what you do, so I'm going to come and work for you. So she'll be on the little booth outside later, so if you want to talk to someone who's been a user and that has now crossed the line, come outside. So let's talk about improved patient comfort, or improved patient care. These are 2 papers that have come out, ProMedica, EWBC, both US sites, proving many more cancers detected by using our software to then say to these women, we're going to do ultrasound or MBI on you. But then equally then, this is Mayfair, Canada, and if you go on our website, you'll find all these case studies now. Mayfair, ProMedica is up there as well now. We really improved their cost of compliance, so 60% reduction in time spent complying with federal regulations. We improved their breast compression so that the women were much more comfortable and therefore more likely to come back. We drastically reduced here, in this case, 15% of technical recalls. These are recalls where the woman goes home and then you write to her and say, sorry, Mrs. Smith, but the x-ray was not good enough. Please come back. We want to do another x-ray. Each of these really annoys the woman, but also it costs the site $200. So every single one of these you can reduce is a great return on investment story. We charge software as a service for this. Fundamentally, it comes down to a price per woman, and at the moment we started off around $2 per woman US. We're up well above $250 at the moment, and that change has been based on all the return on investment stories and getting good customer reference sites up and running. Annual recurring revenue has been going up very consistently. We're targeting towards 9 million this year, so as it is today, we're about 43% up from where we ended. We just ended our half year, so in November you'll get our half year results, and there we'll talk about revenue rather than annual recurring revenue. Critically then, and if you search for us on the web today, you'll see lots of press releases about the amount of data we've got now. This is just a stunning amount of data in breast imaging, and there's just an amazing amount of material and things we can do with it. As an example, one of our bugbears over the years has been dealing with pacemakers that appear in the breasts. They're pretty rare, obviously, but now in this data set here, we've got enough cases to bring out the pacemakers and then to change our algorithm to actually remove the pacemaker before we compute density. I think that's a great case of big data. So revenue, we're going to come out with the half-year numbers pretty soon. Last year we had a 53% jump over the full year, which was good. But also we had gross margins of about 70%, which gives us the basis for a very scalable, profitable company. Some of the highlights in the 4C that we put out very recently, cash was up over 100% Q2 to Q2. Lots of cash in the bank. Very low churn. Obviously, as a software as a service company, low churn is critical, so it's great to see that. A big jump in total contract value and ARR. Now, the US is great because it's all private screening operating under the FDA, but globally, there's another 40 million women getting screened each year by public screening programs. We are in trials, huge trials in the UK, Norway, Holland, Australia, and New Zealand. And it was a major step for us to get our first public screening program converting from a trial to a paying customer. That was Breast Screen Central in New Zealand about 4 weeks ago. So that's a great one, and now we're really going to go after all the other ones where all the trials have been successful. And I'll just note here as well, one of our aims for the year was to really open up APAC. So we've got a 16th customer now in Japan. So we've got like a nice seed into that market now. Corporate overview, we started off when we IPO'd very, very few institutes. We did a 20 million raise earlier this year. We've got very strong institutional support now. We're starting to see some of these institutes actually coming through and going substantial, which is great to see. These are a mix now of Australia, New Zealand, Hong Kong, and UK institutes. If you come on some of our 4C calls, you hear now a lot more American and Canadian voices coming on there, which again, I think shows our global interest that we're starting to generate. Just, last couple of slides. Aim with the capital raise this year, increase market share in the US and risk go on to dominate it. So we're up to 15 people there now, and our target for the year is at 9% of the market. Bring more products through, so we expanded the team in Wellington, and we're on the way to introducing a new product. This is Volpara Live, just here, real-time quality control. So that is due to launch in 4 weeks' time, our biggest trade show and expansion into Europe. I'll just say, last slide, this is RSNA. This is 60,000 people, so Pro Medicus will be here and a couple of other ASX companies. This is our biggest show of the year. It's the World Cup of Radiology, and we're looking forward very much to getting there and really showing the world what we've done and where we're going. So with that, I'll end the talk.
Thank you very much, Rob.